We are live.
Okay, thank you. My screen is visible?
Yes.
Okay, thank you. Thank you, sir. Welcome, everyone, and welcome to this No Thrombosis National Workshop. Yet another exciting case study today. Please let me allow me to introduce our faculty for today. So, our course director for today is Dr. Shashi Kumar Jaiswal. He's a HOD, Care Hospital, Banjara Hills, Hyderabad. He has more than 40 years of clinical experience and held significant position and worked in renowned hospitals like Kim's Hospital, Max Cure Hospital, Yashoda Hospital, KFSH in Kingdom of Saudi Arabia. With over 4 decades of experience, he has expertise in managing complex neurological condition. He has various clinical interest in migraine, headache management, Parkinson's, and many other neurological disorders. He has been a member of renowned professional bodies such as American Academy of Neurology, Indian Academy of Neurology, and Indian Epilepsy Society. He also served as a president of the Telangana Neurosciences Society. His exceptional contribution to medicine has earned him accolades, including a gold medal from Osmania Medical College. Welcome, sir, for the today's meeting.
Thank you.
We have moderator for today, Dr. Sandhya Manoranj. She is the HOD Deccan College of Medical Sciences, Hyderabad. Her area of specialization is stroke, movement disorder, neuro rehabilitation, vertigo. She has over 68 publications in national and international journals. And amongst her achievements and awards, a few are Dr. Sam G.P. Moses Gold Medal for National Topper in DNB General Medicine 2004, Dr. G. Arjun Das and Dr. K. Jagannath Award for Best Paper in Stroke in INCON 2019, Best Paper Award in TNSCON 2019, ICMR STS Project Grants in 2020 to 2024, International Vestibular Rehabilitation Certificate 2024 from American Institute of Balance. Welcome, madam, for today's meeting.
Thank you.
And the speaker for today's meeting is Dr. Shyam K. Jaiswal. He is the Chief Consultant Neurologist, KIMS Hospital, Gachibowli, Hyderabad. He has completed 100 epilepsy surgery and 600 stroke IVT in past 14 years. He has been DNB teacher and guide in KIMS Hospital, Hyderabad. He has received 13 international travel grants and scholarship and 2 international observerships prizes. He has presented 19 international and 24 national presentations, 10 international research publications in peer-reviewed journals, and organized 3 national and state conferences engaging more than 1,500 neurology practitioners all over India. He has been PI and co-PI for several studies in neurological conditions, contributed to chapter in biomedical imaging book, and trained more than 20 medical students, and has been member of many societies and communities. Welcome, Dr. Shyam Jaiswal. And with this introduction, I'd like to hand it over to Sir.
Good evening, everyone. It's my pleasure to chair this session. Now, interestingly, if you know, the topic for today is no thrombosis. So KNOW and no thrombosis. And it's a national workshop, and I thank the organizers for giving this opportunity to us to share our experiences. So we'll be discussing a few interesting cases on thrombosis, which Dr. Sham will be presenting, and then we'll have questions on that, and we can discuss our personal experiences. So I invite Dr. Sham Jaiswal to make his presentation.
Sir, so to start, sir, or?
I think we'll set the ball rolling. You can start the presentation.
Okay, sir. Right, sir. Yeah. You can see my screen.
Yes, sir.
Dr. Pratiksha. Yeah.
Yes, we can see.
Yeah. Thank you, sir. It's pleasure to present in front of sir. He is my teacher, and Dr. Sandhya. Thank you for joining, and you both are very senior to me. But I just want to present few interesting cases which recently we normalize this. That is a tale of tooth thrombolysis. So, starting with the first case, she was 75, 4-year-old female, known diabetic hypertensive since 5 years. She presented with the weakness of right upper limb, lower limb, with inability to speak. So it's almost came with 90 minutes, 1.5 hours prior to arrival to ER, and there was no other kind of bulbous feature like dysphagia, and no blurring of visions, headache, vomiting, and there was no fluctuating weakness. It came with the progressive weakness. Means in a general ARVC was conscious, pulse BP was around 150, 100, GRBs was normal, very febrile, and then this all information I got through my ER physicians. She came in the early morning only, and the CNS this Jesus was around 11 with the V1. She was following the commands, and there was left gauge preferences, right human facial palsy. She was Broca's aphasia. Speech output was zero, but she was able to comprehend some simple commands. She was able to follow lifting hands and legs, and power of upper limb was zero, lower limb was one, right side, and uh, detail was normal. And there were no cerebral, no sensory signs. The total NHS was 15, with the including gauge preferences. It was little bit of following commands. Power is almost zero, 4 plus 4, and she was Broca's aphasia. And facial palsy was almost complete. So NHS came 15. Another system was normal. So the clinical diagnosis was acute stroke with right hemiparesis with the NHS 15 with Broca's aphasia, and then I told that patients to sit for the scan. Actually, in our in the KIMS Gachibowli, we have the same floor near the ear. We have the CT scans, MRI scan. So when the patient comes a very short window, I just tell them, better to go with the diffusion only, the MRI only, and thrombolyze then and there only, because sometimes we miss the small infarcts to rule out the stroke mimics in the CT scans, and we can do the angio also in the same sittings and can activate our IR team, interventional radiology teams. We have support with the interventional radiology teams from the main center. So we shifted the for the scan, and it was DTI was only 30 minutes. And the MRI we found this is the image we found. You can see this is left side MC territory, mainly the superior divisions, suprasylvian infarct was there, and you can see the change in the ADC. And this was the image in the flare. Flare, you can see it is almost, we cannot appreciate anything, since definitely diffusion and flare mismatch was there, definitely suggestive of hyperacute infarct. And in the MR angio, we can see that that's inferior division we can see on the left side, but superior division is definitely not seen in the MR angio. And I discussed with the our radiologist, neuroradiologist, and he was showed the thrombus also. I'll just review literature also in between with the scans, in between my presentations, and we take a opinion from the Dr. Sandhya and comment from the Dr. Jaiswal sir. So usually, ideally, this is the protocol we should follow. What the International Headache Organization has told about that, we should evaluate within 10 minutes. Stroke team should be notified within 15 minutes. CT scan should be done. Universally, CT scan is the choice of imaging for the stroke. Should be done within 25-30 minutes, and CT lab should be interpreted within 45 minutes and should be given. Whatever thrombolysis you can give within 60 minutes. This should be door to needle time should be 60 minutes, door to imaging should be 30 minutes. So usually, our case also, door to imaging time usually have 30 minutes. We usually get the imaging as soon as possible because it is on the same floor and it's just nearby, 30-40 minutes from the emergency. Then we consult the attenders and we formalize. In this case, I prefer the LT and we given the total 60 mg dose with 6 mg bolus and 54 mg infusions. The patient was, the family was, they're more educated and they were knowing about this thrombolysis things, and then so we consult immediately admitted and we started the infusions. Donor times in this case was about 90 minutes and from onset was 2.5 hours. Now, these are the window periods. You know that this all LTPA started the way back in 96 and in India came around 2000s and different trials from the NINS trial, you know, the landmark trials. And then the window period, it was 3 hours before, then in the 2008 with the ICAS 3 trials that actually window period extended up to the 4.5 hours. And then you can Yeah, and you can see that in the last 1 decade, there's so many trials, games like MR Clean and Dawn trials, Diffuse 3 MR Witness, and they're trying to extend the window period, but mainly for the EVT and the tentative place trials, where the extend 1 8 tentative place, where the extended the for the large vessel occlusion, they extended that the window period up to 6 hours. And these are some guidelines from European stroke journals because some definitely we see many patients with the high blood pressure and high blood sugars, but definitely there we can thrombolyze, we can just lower the BP with the labetalol and whatever agent available, and we try to down the sugars with the insulins. And definitely quality of evidence, the low to moderate and strength recommendations are strong. Definitely, it's not that patient having high blood pressure, high sugar, it's not thrombolyzed. So we can definitely thrombolyze such case also. So these are the reports for there. What count this hemoglobin count was okay, and the renal parameters was fine, and the liver function test was normal, and the PTN was normal, thyroid was normal. She was vegetarian, so definitely she has vitamin B12 was around lower side 370, and homocysteine was high, but the cholesterol was normal. Homocysteine was 7.7, so more than 12, and the lipid profile was normal. HbA1c was little bit higher side, so diabetic. The echo was normal, and this is the post thrombolysis. We can see the image. They were showing that definitely the all the infarct we see in the diffusion on the next day. The infarct pass was the hemorrhagic conversion, and definitely it was a little bit scary, but patient was stable, mildly drowsy, and this is the CT angio. Usually, I get the whatever when that we thrombolize, I get the CT angio with the CT brain also. This is why whenever I see the large vessel occlusion, I get the CT brain angio to see the clarity of vessels. So here also you can see that on the right side, the superior division is not so appreciable as the left side we can see. But as I was showing that there was definitely hemorrhagic conversion, I started the anti-osmotics, mannitol and 3% initial after bolus and started the infusion also. Given because hyperhemosystema was the B12 lower sides, vegetarian, I started with the on B12 and I target the blood pressure on 150 to 160 and sugar less than 150 milligram per cent. And and you can know this is the things we know about that spontaneous ICH we see post thrombolysis, and there's a class 3 definition. There's a grading for the spontaneous intracranial hemorrhage post thrombolysis. So you can see in this case it was almost pH1, not pH2, because it was not significant mass effect for the midline was not so shifted was there, and this is the things actually we should know at least for the our resident doctors. And this was the image just 2 days back, and there's no increase, little mass edema is there, but not so midline shift was there, and continuing desmotic she was her GCS was almost 6 for 11 12 was there, and power also improved, and she was doing well. And then I started because it was hemorrhagic conversion big. I started with I followed the 0 1 3 7 14 guidelines, and list after 1 week I started the low dose 75 milligram cosprin, starting high dose, and BP was a little bit higher. Sir, once I started Corsil plus and sugar with OHA, lymph physiotherapy, speech therapy I advised, and so was doing good. So fine novice was there. This right hemiplegia with Broca's. Definitely close to one large vessels. Embolic. Door to image was 30 minutes. Door to nail was 90 minutes. Thrombolyzed with RTPA. NHS on discharge about 4. I mean, so almost as powers. He was able to lift the hand. Power was 4, and definitely aphasia was. She was able to at least verbalize some words, and her gauge deviations come down, and it was almost normal. Facial deviation was come down, and definitely MRS 3. So these things I wanted to so that this Donald is very famous that is so take about the different flare mismatch which was there in this case. Usually we used to follow this wake up clinical trial where we see the different flare mismatch, and they say that if the different flare mismatch is there in the wake up patient, we can thrombolyze easily because it could be the window period less than 4.5 hours also. And uh, this you can see that the window period have extended 9 hours also, as I showed that flow charts and different frame mismatch was definitely simple technique, and where the CT perfusion possible, there CT perfusion mismatch also we can see. Usually I do the ASL imaging also. Is a the free software available with all the MRI. If the different ASL mismatch also there, there's definitely show the mismatch between the penumbra and the ischemic part. And then definitely BP sugar control is very important. This was the first case, sir. Yeah, so I'll uh, want to get comments from both of you, sir.
Thank you, Dr. Sham. That was an interesting case, and then you followed the protocol, and obviously you were rewarded, and the result was really good. Dr. Sandhya, you want to make any
Yes, sir.
comments?
Yeah, Dr. Sham, it was a wonderful case presentation. Actually, it was more interesting because you showed the case along with little bit theory points for the 1 minute for the students and the young neurologist. Just I want to add, Dr. Sham, now the new protocol, the timing, just this is an add-on point which I have learned recently, that the door to needle time should be now it should be more stringent. It should be kept 30 minutes. Because they have found that when we delay the thrombolysis, every 15 minutes delay in thrombolysis will reduce by 16% the outcome at 3 months of MRS of 1 to 2. So our aim should be 30 minutes so that at least we'll reach 45 minutes or 60 minutes. So that is the important thing. Every 15-minute delay will reduce the outcome MRS of 0 to 1 by 16%. That is the one add-on point. Then I wanted to know that regarding the antiplatelets, is there any specific guidelines to start antiplatelets after ICH? Do you follow that, Dr. Sham?
I think he mentioned the timeline, no? That he followed the guidelines.
Yes, madam. Yeah. So, uh, sorry, madam, I missed your question, madam. Yeah, 0137. Yeah. So I follow that 013714 that you must have heard about that very famous stroke specialist. I forgot his name. Is when the TI is there, we
Yeah.
start with the 0 and a small petechial there. We can start after 24 hours. If the big hemorrhage there, we can start after 7 days, and the 21 days if the big bleed is there. Usually I follow this when the patient on the IC bleed and the patient required the DOX or they required the warfarin. In that case, we follow that 0137 14 21, madam. Yeah, like that. So
Yeah,
in that case, because the
thank-
hemorrhage was a little bit bigger size and the hemorrhage conversion, so I just waited for the these things. Mm.
Wonderful case. Congratulations, Sham. Now you can proceed to the next case.
Yes, ma'am. So this is the second case with the Mrs. LG. She was again 53 years female. She was diabetic hypertension is 3 years, a little bit younger female. But in the last the 2025, she is very what to say stormy health issues. She diagnosed with the renal cell carcinoma. She underwent nephrectomy and in the January 25, and after the nephrectomy, she started on the immunotherapy that what is that Pembro monoclonal antibody, and she was taking every third weeks, and last dose she was taken June and And she had the Mets also on the D7. For that, she underwent the laminectomy and decompressions, post decompression in March 25. She also presented with the acute onset weakness at upper limb, lower limb with the inability to speak. In the 90 minutes again, with the in the prior to arrival to ER, she came in the early morning time. Again, she doesn't have the same other bulbar history and fractional weakness. She had BP 150, sugar was normal only. And Phoenix examinations, she was little bit more aphasic. She was occasionally following commands. It was not broker. She was almost reaching to global, but sometimes she was following commands. But gauge preference was not there as the previous cases. Facial pulse was also not severe like the previous cases, but power was almost zero only for her case. So her NHS came around 14 because she was global aphagic, but there was no gauge deviations, and the facial weakness are not so severe. And then again, see again the same clinical diagnosis, right hemiparesis with the global aphasia with an HS14. Here, because of the sometimes it take a little bit more time to get the imaging, and in the imaging you can see there was on the left side it's almost AC-18 infarct was there. You can see on the pyramidal infarct was there on the left side, and you can see the ADC reversals here, but not very big infarct like the previous case, but the almost symptom was like the same. In this case, I thrombolize with the tentative place with the 15 mg, zero point 0.1 mg per kg, and given the 15 mg bolus. Here, it took little more time because the ER team informed the neurosurgeons because they underwent surgery, informed the MEDONC team. But I told you because it's all more than 4 weeks and this is more severe, so there's no contradiction for the thrombolysis. But almost take it, given this thrombolysis, almost 3.5 hours. And her blood parameter was normal. The count was okay, and creatinine was normal, sodium was normal, electro was normal, APD-PTNA was normal, and her homocysteine was normal. Her fasting lipid profile was normal. But one interesting thing was that in the echo we found she had mild MS, and because she had the carcinoma case, I thought it could be the and the ACT infarct. We see many times the embolic also cardioembolic. So I thought it could be the meningitic endocarditis, which we see the in the neoplastic cases. And this is the post thrombolysis scan, and the post thrombolysis scans you can see there's no bleeding and there's no increase size or infarct. We can see and after the 25 started on double antiplatelet. Usually I follow the large vessel disease. I start all the double antiplatelet. Can know the chance trial, the Chinese trial where they start a double antiplatelet for 3 months. I give the hydrostatin 325, Colpet 75, and 80 mg of statins, and I usually don't start the antihypertensive for the stroke patients. And I keep the RBS checking regularly 4 hours, and I keep the sugars. I get the tea also because she had this MS was there, and I was thinking it could be embolic, but the cartilage the wall was clear. There was no vegetations was there, and no PFO was there. And then on discharge today only she got discharged with the dual antiplatelet hydrostatin. And this is again the diagnosis was the post-mortem large vessels, that's embolic. Here more dot image dot to nil time, but thrombolize with the tentative place. And NHS came, she was today was almost power was almost holding on. She was able to stand and she was able to follow commands. Speech output. She came from global to Broca's aphasia. So in this case, I just want to say that there was some study was there in NGM 2018 where they say tenecteplase usually should be used when we plan for thrombectomy. Usually we have the stroke WhatsApp group where the ER team, critical care team, neurologists, neurosurgeons, and the interventional teams are there. And we put the image also so that they can also know. So we activate the interventional team also. So because the large vessels, so usually in the study they show that in any large vessel disease, before thrombectomy taking place, have the high incidence of reperfusion and better functional outcome than the anti-alteplase. And this is I was talking about the extend trial in the same, and this also published in NEGM 2019 where they extended the alteplase from between 4.5 to 9 hours. And these were ISO 2021 guidelines a little bit old guidelines where definitely we know that more than 4.5 hours, if the mismatch is there, we can use the LT pledge. And if there is a patient having minimum of sleep and poor perfusion mismatch is there, we can use up to the 9 hours also. But in the recent stroke congress, they have added the tentative pledge also. And I told about the sugars and BP also. This should not be contraindications for the thrombolysis. So these are the very big flow charts where we see that if the patient came with the large vessel occlusions onsets in the less than 6 hours for the minor strokes, we can start any this here the LT pledge, but we can the choice of drugs could be both of them, and definitely large vessel these occlusion people are preferring the tentative place because the better outcome with that trials. And again, three criteria and don't criteria we know, and different mismatch. This one comprehensive flow chart is there for large vessel occlusions. Thank you, sir. Thank you.
Thank you. Thank you. It was another good case which you have presented. Uh, one thing is Dr. Sandhya was mentioning about the time, door to needle time. So
Yes,
it
sir.
has been cut down to 30 minutes, she said. So I
Mhm.
think the modality of imaging which you do when the patient comes to the hospital takes away little time. So
Yes, yes, sir.
you follow the MRI protocol only there.
Yeah, you take now.
You follow the MRI protocol there.
Yeah, yes, sir. So what I do, sir, I take the I have activated my stroke nurse that you take the thrombolytic agent with the patient in MRE only. If you see there is infarct, you thrombolize in the there in the MRI room only. Don't try to shift and then thrombolize and then you continue with the other imaging. Usually, I do the bridging for all the cases. If then a patient required thrombectomy, but we don't wait for the directly go for cath lab. Thrombolize in the MRI room only, and then continue with the imagings with the to see the vessels, and then activate the this thing. I definitely agree, sir. It take time. Stroke protocol take a lot of time. Yeah.
And if you see the door to needle time in both the cases,
Mm.
it was
It
less
was
in the first case, and it was
yeah,
little
yes,
longer in the second case.
yes,
And
yes,
then you had a complication in the first case rather than the second case. So,
sir.
so the thrombolytic agent, does it sound any bell to you? Altiplace or connectiplace?
I'm very difficult to say. I never say on a head-to-head trial for the both. Very difficult to do the head-on trial. But definitely, lots of literature and studies are coming for the technical pledge also, and they're definitely showing the good results in the large vessel occlusion cases.
And one more comment I have: the second case was a known case of malignancy.
Yes, sir. Yes, sir. Yes,
So
sir.
in follow-up, I am sure you would be doing a D-dimer follow-up for her in following days, whether
Okay,
you would
sir.
put her on anticoagulant or not.
Yes, sir. Yes, sir.
That
Totally agree, sir.
Dr. Sandhya,
Yes, sir. To keep the door to needle to means low as 30 minutes, what we do, need to do CT scan initially, sir. When we
Yeah.
know it is an acute onset of hemiplegia is there, and the
Yeah.
patient is coming within 4.5 hours of stroke.
Yeah.
In
Yeah.
certain scenario where the patient is having like stroke mimic, we think it is a seizure like presentation or stroke communal like presentation, or it is a wake up stroke, or beyond 4.5 hours, we can go for MRI brain. That is the better choice. Beyond 4.5 hours, I feel CT will be the better choice if we know clear cut it is acute hemiplegia. This is the one thing I want to add, sir.
Okay. Yeah. Oh. Okay, this I'll keep in mind, and maybe I'll change the stroke pathway
Mm.
in my
Yeah.
hospital. Yeah, yes,
And
ma'am. Yeah,
in my experience, once that inactive place has come, we often use inactive place
yeah,
because we can give single dose immediately, and the
yes, ma'am.
cost is low as compared to the other TPA agent.
Yeah,
And
totally agree, ma'am.
And the ESO 2023 guidelines also says that it is
Hmm.
better than altiplace in terms of safety. And
Yes,
in case of large vessel occlusion, it is a better choice.
yeah. The large vessel is definitely the better choice. Thank you, please. There.
Mm.
and when we say it is better as far as safety is concerned,
Hmm.
Yes,
people
sir.
say that, but what about the efficacy? So that question comes in. Is it different? So anyway, we cannot have a head-to-head trial.
Yes, sir. Efficacy wise, both are same.
Actually, in large vessel occlusions, comparative studies have shown it is better compared to because there is a basis for that. In large vessel occlusions, tenecteplase is better than in alteplase, and you can see all registries, and because sometimes trials are in controlled environment. If you look at the real world evidence published from France, from Australia, and other studies, they all show tenecteplase is better. Obviously, I mean, as you rightly know, stroke is a complicated disorder. You have to balance out all these parameters, but these studies have established tenecteplase is better.
So
That's
the
what
problem is that with Western countries and Asian or Indian population, both are differently. The vessels characters are what my experience is there. Jaswal sir is there more experience, but what I've seen last 15 years, we see more of the large vessel disease, and more we see the atherosclerotic, and the vessels are not so. Diabetes is very common in the India, and just extrapolating the Western data and Indian, I'll be very little bit more apprehensive. And coming to the SIH, what we see, just I saw in my first case, I've seen with the tenecteplase also in the large vessels. It's not that there is a safety concerns is only with the acrylic. Tenecteplase, if the any cases when the infarct size are more and the comorbid is more, if you ejaculate, if you tenecteplase, both is going to bleed. That is my personal experience. Sir and Dr. Sandhya can comment.
See, I have more experience with tenecteplase than alteplase.
Mhm.
So the patients are doing better and outcome is good, and MRS is 1. Sometimes I feel these are my patients who had done semiplegia and they are now coming walking. That is the one thing. And then we know the extent, they have clearly shown that extent IA-TNK. They have shown that total reperfusion in large vessel occlusion is 20% with tenecteplase, and compared to alteplase, it is 10% only alteplase. That is the one thing.
Yeah, I just want to share one experience personally. When this thing came in, and when at NIMS, when we used to give the bolus of Altiplace, and after that, then you give the infusion. So I used to be very, very apprehensive for that 1 hour or so. And if the patient started complaining of headache, we used to stop the infusion. I mean, I did it in 1 or 2 occasions, honestly, because I was afraid whether it's is he bleeding. Anyway, we didn't have all these facilities side by side so that we can immediately pull in the patient and have a look. So I think here the advantage is you have given. That's the end of the story. Now you have nothing else to do. You have to face the consequence as well as tenecteplase is concerned. But alteplase again, it's you're giving the drug over a period of time. So again, you have a shift of mind. You can have apprehensions sometimes.
And just to add, I mean, bleeding will be there because ultimately we are giving thrombolytics. Alteplase is similar to tenecteplase, 98%. There are mutations in 3 amino acids. So we will know that, but the bleeding events are less compared to, at least this is what the data shows from number of countries and globally. So I would not say there is 0%. Whenever we manufacture, whenever I present, I'll say, they are thrombolytics. The way the disease is, you will get bleeds. Maybe 1%, it may be 0.6%, but that patient happens to be, you are treating that patient for it is 100% for that patient. So,
Any questions, Dr. Sandhya?
So just I want to add, sir, one additional point. See, now we are thrombolizing up to 9 hours, intravenous thrombolysis. There is no guidelines for up to 24 hours intravenous thrombolysis. So one new study has come, home trial study, which was presented in the International Stroke Congress this 2025, where there they used alteplase instead of tenecteplase. Alteplase they have used for the patient from 4.5 hours to 24 hours. And they found the benefit was there, around 23% benefit was there as compared to the standard therapy. So I think we need to do this study for Indian patients also. Intravenous thrombolysis beyond 4.9 hours, that is 9 to 24 hours. That is the HOPE trial that we need to study further, sir. That is the recent one which came.
For the 9 or 24 hours, definitely
Yeah,
we can do
hope
the
trial,
EVT.
intravenous.
We can do very comfortably, but
Mm.
beyond 9 hours for thrombolysis, there will be lots of ethical issues. We don't know. We can
Yeah,
get
that depends
get
upon selected patients, image
Hmm.
guidance. So they are telling that point is there, image selected guidelines of the patients. So
Hmm.
the viable tissue is there, then if up to 24 hours also we can thrombolyze.
That will know on the perfusion
Important.
imaging
Yeah,
only.
yeah, perfusion.
Yeah.
So can we take the questions from the chats?
Yeah, please.
Pratiksha, is there? I can't see, sir.
Ma'am, currently there are no questions, but let me check it again.
But Dr. Amit, Sandhya madam is from Deccan HOD. Take the help from madam and Jaiswal sir का भी बहुत सारे cases हैं. Let's publish some papers from madam, sir, and I can also contribute some cases at least for the मैडम के काफी टेक्टिव केसेस हैं. मेरे बहुत सारे एक्लेज केसेस हैं. टेक्टिव प्लेज
So we
रिसेंटली
can,
स्टार्टेड.
I mean, हाँ कुछ वही था सर से हम मिले थे.
लास्ट 10 years में जितने भी मेरे थ्रोम्बोलाइज केसेस हैं मैडम के, वी कैन हैव सम आइडिया कि ना what kind of patients, kind of large vessels and small vessels and embolic cases and ESUS cases, and we can have some kind of complete data in the same time period because we both stay in Hyderabad only. So that we can have a
we can, yes, I mean we'll have to, yeah, some time frame we take and just try to compare, do some
like
matching
yes,
between
last 10 years
place,
में some
place,
we can
and because in India we have so many patients getting thrombolyzed, but the data is not available in the public.
that is the thing. Because we both in the same city, and madam is from the Deccan. She has more cases of tenctiplasia, more I have more cases of actylic. In the same time periods, we can divide what kind of cases madam used tenctiplasia, what case I have with actylic, and we can see the complications and outcome and also that thing.
We can
Good
do
idea.
retrospective analysis. Retrospective analysis.
And then we can add also, for last 10 years,
No, it's a good idea. We'll have to, yes, we'll plan a strategy how best to combine the data and work on it.
So, ma'am, no questions currently. No questions.
Okay.
Perfect.
Yes, I take this opportunity to congratulate the Gennova team for initiating such a program. No thrombosis. Thank you. So that because we know the reason CME, we have heard that in India, though patients came within window period, only we are able to thrombolyze 1% of the cases of acute ischemic stroke. So we need to go far ahead. We need to at least thrombolyze 10% of the cases. So knowledge sharing is very, very important, and each one teach one, very, very important, so that we will act fast.
Recently, I am starting a campaign, just announcing here today, and maybe I'll launch the media launch in the next week. I'm launching a right for thrombolysis. All the stroke patient has right to get thrombolyzed. So that I am starting this campaign with the hashtag, and I want all your team and all the neurologists to come forward for right for thrombolysis. All the stroke patient has right to get thrombolyzed.
Right to thrombolyze.
Anyway,
So there is no cutoff of 80 years. Even above 80, that rule has changed. Above 80 years also we can do.
85, 90.
Above everything we can do. And then 16 years or more.
Yes,
so that
ma'am.
Again reduce children killing.
Yeah.
That's a nice thing. You should come up with it.
सर आपका सपोर्ट चाहिए जयसवाल सर. आप मेंटर रहेंगे हम लोग के तो विल हैव सम काइंड ऑफ कॉन्फिडेंस और थोड़ा सा हिम्मत मिलेगा हम लोग को.
Sure. Now, as I am at CARE, I think we can do more of academic work.
Yes, sir.
Okay. Sir, still no questions. Is there anything else, sir?
I think we're good to close. Dinner time. The family are waiting.
Yeah.
Thank you.
Thank you.
Thank you.
Thank you, sir. Thank you, ma'am. And thank you, Dr. Sham.
Thank you so much.
Thank you, sir. Good night, sir.
Thank you. Thank you.
Good night.
Bye. Bye.